So, now that I've explained to you some of the reasons why we have to pay attention to chronic hypertension in pregnancy because it can become so bad, let's talk about how we can manage it with medication to decrease the maternal mortality as effectively during pregnancy as at any time. Lowering the diastolic blood pressure greater than 100 millimeters mercury can reduce the risk of morbid events even over 10 months. So basically, previous research has shown that if you have a diastolic blood pressure that's greater than 100 and you try to lower it, it will reduce the risk of morbid events even over a 10-month period of time. That's very significant. So let's move on. Now, antihypertensives can be associated with teratogenic effects. Here it says morphologic teratogenic effects and gives the example of ACE inhibitors, which can embryologically change the kidney formation during the first trimester. So that's not a good choice. Now, there are other antihypertensives that are associated with maternal and fetal cardiac output in animal studies, including propranolol. So that's not a good choice. Other antihypertensive drugs act by decreasing cardiac output or systemic vascular resistance. And this may affect blood flow to the uterus. So it's best to avoid drugs that decrease cardiac output. Antihypertensives that act on total peripheral resistance may increase or decrease or have no effect on uterine perfusion. So you understand what I'm saying? What I'm saying here is that we want to avoid those medications that are going to affect the perfusion of oxygen and blood flow to the uterus, and look at ones also that are not associated with morphologic teratogenic effects like ACE inhibitors. But the good news is we have many choices. So let's move on. Now, this is a table. You can take your time to look at it carefully. I'm not going to go over the entire table, but I just want to present different agents here, including thiazide, methyl-dopa, hydralazine, prazosin, and clonidine. And what is listed here is their mechanism, how it affects the cardiac output, how it affects the renal blood flow, how it affects the maternal status, and how it affects the neonatal status, so that you can make your best choices. Looking at this particular table, methyl-dopa is the only one from this list that's really been shown to be a good choice in pregnancy. Here we have another list including propranolol, labetalol, reserpine, enalapril, and nifedipine. Of this list, the best choices for a pregnant woman are labetalol and nifedipine. And when I say best, I'm talking about from my experience where I'm from. You have to always consider what's available and looking at the risks and the benefits to really decide on one drug, or two, or three. Now, diuretics. So diuretics are like the thiazides. We know that they should be avoided in pregnancy because they deplete the intravascular space, which has been shown in women who have been on diuretics early on in pregnancy. And this is associated with a significant increase in perinatal mortality. Try to never use this in preeclampsia or growth restriction.